di Siena. I'm from Italy, and Palio di Siena is a horse riding in Tuscany. And looks just riding, but in these competitions, the riders can have very hard injuries, and the shoulder is one of the most affected. So before everything, we have to say that the concept about instability has changed over the years. So the concept and the treatment, and treatment is dependent on the country you are, or in the continent you are. So this is the classification given by Pascal Boileau, ISIS Severity Index Score. And he did this and wrote it in 2007, just to say that the arthroscopic procedure to treat the Bankart lesions may have unsuccess, so a failure rate that is very high in people that are involved in collision contact sports. They are male under 20, or they have some minor instability, or they are lax. But we know that this is individual on the individual sportsman. So the same lesion is different in elder people or in young people. But the problem is that most of Europeans, they are following this severity index score, and some of the surgeons, they didn't read the paper, the paper that was written by Pascal Boileau. Pascal Boileau is a very clever surgeon, very clever man. But what compared is what he called the gold standard arthroscopic Bankart repair, compared to the Latarjet, open Latarjet. So this that was by him called the golden procedure, the golden arthroscopic Bankart procedure, was a procedure made with 3 resorbable anchors that he loaded with single polyethylene suture, so resorbable suture. And I mean that no one today would use the same technique to fix a traumatic unstable shoulder. So years by years, we are improving probably the outcome of our procedures. And I would mean that today we have, we still have good solutions for people that has traumatic Bankart lesions. So trauma, what's the trauma? This is a guy paratrooper of the Italian army. No trauma, apparently, because he did not have a dislocation due to a contact, never dislocation. But look at how the speed and the stop, the Earth's gravitational acceleration can get this guy in trouble with, and he produced this kind of lesion. So this is a fracture-like more than a bony Bankart. And so trauma can occur and can be a disaster, even if we do not have really a bad trauma. But we arthroscopically today, with heavy, strong sutures, with by a double row technique of suturing, can assess and can treat this patient right to heal right to heal the tissue, the bone. And one that I want suggest, what I want advise, one message, take-home message is please do surgery in at a risk population at the first episode. Do not wait along. Do not wait for the resorption, bony resorption, or attritional bone loss after many episodes. Preoperative imaging is crucial. This because you can miss the proper direction of the lesion. So this guy was treated at the anterior side, and the lesion is the posterior. And so very, very careful, watch the images and do the clinic. So we know that in a bony lesion that can cause a deficit of 25%, we have to move to a bony procedure as a Latarjet. But when the bony deficit is much more, we have to go to allograft, and the Hybinet is the procedure we could use. Scusami, chiudi la finestra. Grazie. So this is really a fracture. We have to distinguish to fracture from bony Bankart. Fracture is when there's not just a pull by the attached ligaments on the glenoid rim. This is a fracture of the fossa. So we can consider both sides, glenoid side and the humeral side bone. So may have a deficiency on the glenoid side and on the humeral side. Yamamoto in 2007, he described properly the humeral deficit given by the Hill-Sachs lesion. The deficit of the arch, articular arch, is the one that is from the tendons insertion to the cartilage, and so included the cartilage and the glenoid surface at periphery of the lesion. So, and thus was developed the glenoid tract. The glenoid tract that is what is at risk for dislocation because non-contained by the glenoid, and what is contained. This is on track, and this when the lesion is coupled, is combined the head lesion with the glenoid lesion. This is off track. And my friend, my close friend Giovanni Di Giacomo, and other as Itoi and Steve Bankart, they described well this problem, and they went to give some message. One is under the 25%, if the lesion is off track, but you can, by remplissage, get the humeral defect controlled, this can be treated by soft tissue procedure as a Bankart procedure. Over that, you have to go to a Latarjet procedure. But we know that there is another subgroup that is between 13 and 25% that is at risk, and there we can debate about the procedure, what to do. So some other lesion is uninfluent. So this is a very, this is not deep, very superficial, and you can miss it not treating that. Surgery. So open surgery is considered by the most of the US studies as the choice, especially for patients that are involved in contact sport. This, so you can address the Bankart lesion, and at the same time you can address a capsular folding, capsular plication, much better than we can do by arthroscopy. But this is a matter of debate. So arthroscopic bony Bankart, arthroscopic Bankart versus open Bankart is till today said as less efficient for to treat the instability. But most of us, we are doing arthroscopic Bankart, and we have to improve our technique. How to? So we have strict, when we have recurrent dislocations, we have stretched the soft tissues, and the stretched tissues not just on the anterior inferior side, the one, the direction for the instability, for the humeral dislocation, but we stretch the interior hammock, axillary hammock, and we have to treat not just one side, but the whole hammock. So my preference is to treat all the time by detaching the capsule, by folding the inferior labrum, by tightening the posterior inferior as well, as to have the best way to hidden the axilla to the humeral head, so to improve the stability. And this is, so you can improve the stability by fixing the first anchor at hour 6. And this is for me crucial. And so how to do that? You cannot often reach that spot by an anchor coming from the anterior inferior portal, the mid-glenoid portal. So you have to go from a portal that is a posterolateral inferior portal, so an additional portal. attritional bone loss. So if patients they have thousands or thousands of dislocations, no way you have to support the bone. Otherwise, the recurrence could happen in by years or just by a few months after the repair. Again, you put an anchor very distant, and you have to reduce the inferior part of the glenoid, that is the narrowest, and go a little bit up, and you have to add some graft. And this is the arthroscopic bone block. I did that with my friend Ettore Taverna in 2005 first, and then there's an evolution of that. In this case, you can go for a Latarjet. It's up to you, but a bony implement, bone grafting is crucial. So don't miss that we may have an anterior lesion, but we can have at the same time a posterior superior or posterior lesion as well. And we have to treat all the lesions that can affect the shoulder stability. We can have bidirectional instability and attritional bone loss. So some patient can be a sports guy and can have a dislocation or several dislocation in one direction, and by another type of mechanism can have a deficiency in the opposite side. So there's some traumatic bilateral anterior-inferior, posterior-inferior deficit. And these are examples. These are examples. And this is what happens. So you have a narrowing of the interior glenoid. And so you can do a repair with either a repair or a grafting and a repair if there's one side that is dominant. But care, because you can have bipolar, means soft tissue lesions, meaning tissue detached from the humeral side and detached from the glenoid side. And this is a Hagley lesion along with posterior and then anterior. But this posterior lesion is very huge. And this can be a problem if you preoperatively have not the idea that this would be the lesion you have to treat. So we have these kissing lesions. What to? You have first to put anchors in at the labrum, but you cannot put just these anchors. You have to bring, to punch, to hold the labrum and fix the labrum and the capsule back to the neck of the humerus. And this is what happens. You can restore a nice stability. And then this is the problem that you should avoid and care. Just treat the patient at the first episodes. The first one, if young, but do not wait for lesions, added lesions. If there's an anterior and a posterior instability, you can do the same that you do posteriorly. So we do a remplissage posteriorly, And we, in this case, look at, this is the subscapularis, this is the reverse Hill-Sachs lesion called the McLaughlin lesion. And we fix the subscapularis into to the bone here. Now we have new devices. So we have all suture devices, and this is much better because anytime we do a surgery, this is a disaster. But anytime we do a surgery, as gross are the devices for fixation devices, as more you jeopardize the bone, and so you are treating non-bone deficient glenoid, and after the surgery, you if you would have to revise it, you would have to revise deficient, bony deficient glenoid. And look at the patient. When the patient is so young, as this patient that has the growing cartilage opened, so you do not have to fix with such very strong, very stiff devices. This is the arthritic changes in very few years. So you may have to manage a guy that is 22, 23 years old with such a problem. I told you the posterolateral portal. This is the portal. So patient in lateral decubitus. And this is the portal I use for the R6 device, anchor, to reach this very distal part of the glenoid. This is the anchor. This is at R6. And in this way, you can gather the capsule and labrum at the axilla, and you can restore the volume at the axilla with non-extra volume to have the shoulder, the humerus protected. Posterior traumatic instability. This is just posterior, but the clinic is very efficient to tell you before the CT scan that instability is posterior. And we can see here, so anterior, this is the subscapularis with the McLaughlin, and here the posterior lesion of the cartilage and labrum. And this is another, and this is what we did first. In this case, in some cases you have to go a traumatic instability, but the arthroscopy is not sufficient. You can have to go by open surgery as this to fix the subscapularis to the McLaughlin defect. And this can prevent the same way as the remplissage does in the opposite instability. This gives stability. Posterior bone block and anterior humeral bone graft. So this is a patient with multiple very high energy traumatic events, and we had here to put a bone block, so button block posterior, and here the very huge lesion is addressed with a humeral grafting. So attritional bone loss, and this is what we already saw. And okay, and when we say So in many cases, we can do a Latarjet. Yes, we can. This is not a procedure not for dummies. And this is a very demanding procedure, especially when there's a bilateral deficiency. This is what did Laurent Lafosse, that is a very a master of this procedure. But even in the hands of the masters, we can have some suboptimal result. And so I went to arthroscopic Latarjet in order to be able to fix the posterior and the anterior lesions as an instance, posterior remplissage associated with an arthrolatarjet. So this is the Latarjet. This is when in 2011 I started in Italy. Then some surgeon loved the procedure and went out with this. I did not after a couple of years. So, and thank you again for this kind invitation, and we can, when you want, open the discussion.
So, yes. Hello.
Hello. Yeah.
Yeah. Please, anybody wants to ask question to Dr. Enrico on his presentation? He showed few of his X-rays, especially the one which had almost 4 screws in glenoid. So it's very difficult to manage a situation where you have huge bone loss. Enrico?
Yes, very difficult. And don't miss that if you have to manage arthroscopic open procedures at the same time. Otherwise, you would stress the indication to the procedure you are most confident with. So a society should teach the surgeons how to manage arthroscopic open, not just one procedure. For the very large deficit, I prefer to take the iliac crest graft more, and for the deficit that is between 25 to 35, no more, you can go for a Latarjet procedure. You note that the graft, the bone graft in Latarjet is 1 centimeter thick. If you need some more, you have to go to a different graft as allograft, or I prefer the iliac crest.
Enrico, is there any role for the open Bankart repair? Because I'm sure all of us have graduated from open Bankart repair to arthroscopic, and now we are talking about arthroscopic Latarjet and arthroscopic bone block procedure. So is there any role in primary instability of shoulder about the open Bankart repair?
Okay. No, I have to be sincere with you. I go all the times in the first episode to the arthroscopic. This because even in athletes, high-level athletes, even in rugby players, and this is not what is supported by the French people or other people. French people, they would go for the open Latarjet or arthroscopic Latarjet, and U.S. surgeon, most of the U.S. surgeon, they would go for the league athletes to an open Bankart. But for me, open Bankart has no meaning in the first episode because in the first one, you do not have a stretched capsule. So you have just the Bankart lesion to be repaired and a not stretched capsule. The most of the times you have no heel sacs lesions in the first episode. The heel sacs is just in patients that lasted for hours from the lesion to the reduction. And this is not for the athletes. They have immediately onto the field, playing field, they have some support of their shoulder, and they have the reduction. So for me, not. For me, the Bankart, open Bankart can have indication in those lax people or in those that have a stretched capsule with no huge bony deficiency that have to combine the fixation, labrum fixation, along with the capsular shift. And this
Enrico,
is, yeah.
the same thing, can it be achieved by arthroscopic, the capsular plication by arthroscopic means?
Yeah, I will tell you that is not the same. There are several techniques. I wrote about one, but there are several. But you cannot overlap in the same manner as you do by an open shift. You can, by open shift, you can do a near procedure or a job procedure or a rack board, and you can detach the axillary pouch and pull it to fold it along with the proximal fold of capsula. And you can at that time get a interval stitching. So in order not having the superior fold of the capsule that falls down. So for me, not at the first episode, I never do, but I know that many US guys, surgeons, they do, because the long time, the long-lasting outcome are better for the open.
Dr. Enrico.
Uh,
Dr. Enrico.
Yeah.
So, what is the your principal investigation of choice in the patients who have recurrent dislocation? Do you do the MRI in all patients, or do you prefer to do CT scan, or both?
Okay. CT scan in all patients with a recurrent, because the bone deficiency is the main cause of redirecting the procedure from an arthroscopic procedure to an Latarjet procedure or bony procedure. So,
okay.
Yeah, tell me.
Yeah, no. Second is, what is your take on Bankart plus Remplissage? Means I want to know what is your cutoff for Bankart procedure? When do you do Bankart and Remplissage? And when do you say, no, I want to do the Latarjet only?
Okay. When there's a humeral lesion, so heel sacs lesion, and is not just engaging, because all in sacs they can be engaging at a sudden force in the rotation, external rotation abduction. but I mostly go to fix fix by a remplissage almost all the deep Hill-Sachs lesions, because this can improve my stabilization. So nevertheless, it could be not the need, because you can fix the labrum and the capsule, and this the Bankart, and the Hill-Sachs becomes not engaging. But if you fix the posterior infraspinatus and capsule, you have a sling, a improvement in your stability. This not in the very active patients that have overhead players, not in those, because you can cause some reduction of external rotation abduction, but in all patients, soccer players or other patients, when there's a Hill-Sachs lesion, and this is after several dislocation, mostly I do fix by a remplissage the Hill-Sachs.
So what's your recommendation for using number of anchors for remplissage? Is there a definite number of anchors you use for doing remplissage?
So over the 12% of glenoid deficiency. So in the subgroup between 13 and 25, I recommend to add the remplissage.
So the question is, how many anchors?
How many anchors?
Many anchors. Sorry. So the remplissage or the Bankart?
The
Remplissage.
Remplissage. 1, 2. Yeah, it depends on mostly 2 anchors, 2 sutures.
Dr. Enrico,
Yeah.
how do you decide whether you will go for a Latarjet or a iliac crest bone graft? What are your indications?
Over the 35% of glenoid bone loss, I go for iliac crest. If there's a so huge bony deficiency, this is not controlled by Latarjet. We know that some people has a Latarjet procedure, does not dislocate anymore, but is symptomatic. We know that there's a number of Latarjet that are symptomatic whenever they do not have a recurrent dislocations, they are symptomatic. And these people probably someone is because I have some missed lesion at the back but most of them could be because they have a gliding of the humerus onto the glenoid, and this does not get the humerus off because there is this sling by the conjoint tendon, and but they are symptomatic. They feel that the shoulder is does not dislocate, but this is not okay. So in these patients, the ones that have very huge, over 35, I go for grafting, for a bone grafting. There are people that use the distal tibia allograft, but this is not a procedure that can have the numbers to say, yes, all we can go for that. There's the cartilage, and the cartilage cannot survive whenever there's some that supports this technique.
Dr. Enrico, there are two questions which are come from YouTube, and that is, one is, how do you approach the posterior bony glenoid loss? Either you do a open approach for posterior bone block with anterior humeral graft for reverse heel sacks, or you have a different approach.
So I mean that the posterior bone block can be, for posterior glenoid bone loss, can be easier arthroscopically than open way. You can just do a mini incision, and if you have a driving tool as the one that is used for the Latarjet, you can manage firmly the graft, and you can apply the graft onto the bone. You have no risk for nerves. You have no the nerves that in the vessels you have anteriorly. So much easier to go by arthroscopy and assisted by mini open posterior, and with a device holding the graft, and you can apply the graft onto the posterior glenoid and fixed by the screws and go home.
In what position? Is it in lateral decubitus or in beach chair?
I prefer lateral decubitus for posterior. Beach chair, you should put it very, you have a tilt that is not ideal for the grafting.
So you
Kalpesh, you had some question?
Yeah. So, Dr. Enrico, you showed the in arthroscopic Bankart repair the plication of the posterior band of the inferior glenohumeral ligament. So, do you prefer to do this plication in all the cases, or when you see the lax posterior band of the inferior glenohumeral ligament, in which cases you prefer? All the cases?
So I cannot say all the cases, but I say if the patient had many dislocations, so 10, 20 dislocations, I do, because it is impossible that the posterior capsule is not stretched. And sometimes you have a very flimsy capsule, so very poor capsule, and the stitch. So in these cases, the most important is the R6 device.
Which one?
So to pull the axilla this way, R6, not this way,
yeah,
but this way.
Right.
And so in this way, you have some more capsule posterior to be grabbed and stitched, with not over tensioning and not getting the strands as the strand that cut the cheese.
Okay, I think we should move on to the next talk. I'll request Dr. Enrico to start his next talk on non-traumatic or atraumatic instability.
Okay. Do I have the screen shared or not? Sorry.
Yeah, you have the screen share.
You have to share.
Okay.
You open PPT and share the screen.
Okay, so okay. So this is one event of the young doctors of my society when the Italian Arthroscopy Society. Ecco, so atraumatic. So we have.
We can't see your screen, Enrico.
Cannot. Oh, sorry.
So you just open your PPT and share the screen.
Okay, sorry. Share the screen. Okay.
Yeah. And start
See?
this part. Okay.
So
I'll just mute everyone.
okay, so we organize, we sort out training for them, lab training, so as how to read a CT scan, an MRI, and with the courses for them. I'm so happy to have young people about me. So constitutional laxity. We have not the normal people, the normal pattern is very different. Some people has to be lax. If not, they would not able to do these things. This is an Italian dancer, Carla Fracci, that has been the most popular dancer in Italy. She could not do these things if would not be lax. And so these lax people, they have the need for a super joint control, super muscular proprioception, super proprioception to control the joint. So you can hold an umbrella by your index finger, and the umbrella can stay balanced. And look at this is a guy that can stay balanced, but this is a very, very, very difficult to achieve. Not everyone, and someone can lose the ability to balance the muscle forces, to balance the scapula position, to balance the back, the spine, and the pelvis. So in constitutional pathological patterns, you can have capsular redundancy, or the labrum that cannot be evident or not be step fragile, or bone hypoplasia. But look at, I'm by the scope in this patient, and it looks as would be a boat on the sea with a very, very large capsule. I assume this capsule would not prevent any dislocation if the muscles would not be with the proper activity. Someone comes to the office and show you how is able to do these things. So this is not a pathological, but is just a phenomenon. So it is not given that this will develop a instability. This is lax people. This is a people that has agenesia of the clavicle. So this is pathological. The capsular shift, the capsular application is the procedure that is given by Job as the elective procedure for those kind of people. And I tried, a few minutes ago, we discussed about that. I tried to reproduce the Job procedure to reproduce that as in open. And so this is the methylene blue. This is the cut I did into through the capsule. I took the proximal capsule and I fix the proximal capsule to the distal and the distal to the proximal. But I can say that you will never have the same capsule doubled as you see when you do it open. So you can do plications, but by plication you can reduce the volume, the capsular volume. You can tighten the capsule, but you cannot get the capsule thickened. So you have this procedure, but this procedure could lose by the time some of the property. These are capsule applications. When I was to Steve Snyder, I stayed, I followed him. He did this. He was very clever, and I then moved to the plication onto the anchors, so to have a more stiff, more rigid place to fix the capsule. Another important point is the labrum that is not thickened, is not as thick as a wall, to be an obstacle to step off. And some author supposed or advised Smatsen to inject blood into the labrum to increase the stability. So not just the active forces can do the job by themselves, the stability job, but some of the passive mechanism should be necessary to improve the stability in order to deep the glenoid and getting bigger forces to get the humerus off from the glenoid fossa. So the need is to increase the glenoid depth, and this to improve the mid-range instability, the mid-range stability. So these patients are low energy dislocators, and there's not gross bone deficiency, neither in the humeral side or in the glenoid side. This was a procedure I did several times years ago. So I tried to take the palmaris longus, the same arm, affected arm, and to fold the palmaris longus, fixing it to improve the glenoid depth, to improve the height of the labrum. Probably this was too thin to give me or to give the patient a real improvement. Then I went to thicken the labrum with this membrane. I prepared the membrane. This is a porcine dermal matrix membrane, and using it to improve at the end of the procedure the height of the labrum. You can get it 7 millimeters thick, so gives a very, very huge improvement. And this I start doing in multi-directional unstable shoulders to have a combined muscular training by physiotherapists, preoperatively and postoperatively, and some improvement given by the membrane, this folded membrane. This is 5 centimeters. 5 centimeters is enough to be at the periphery of the anterior glenoid, inferior glenoid, and is 7 or some more millimeters thick. So, arthroscopic technique, 3 cannulated portals in 1 accessory. The anchors are double loaded by suture anchors, 3 or more suture anchors. So this is the way from the anterior, and so from the mid-glenoid portal, I take the membrane of the cannula off, and then I transfer this graft into the joint, and this is how to fix it, and this gives deeper and step the glenoid fossa. Indications are symptomatic multidirectional automatic shoulders, or revision surgery for soft tissue failure, or when you go to surgery and you do not find any nice tissue for to use that plicating to get a new labrum. And this, sorry, okay, and this is the chewing gum like capsule. This is I'm watching from above, from the anterior superior portal. This is the posterior portal, and you can see as you have this capsule very elastic, and this is the membrane at the periphery of the glenoid at the end of the procedure. Probably we will have the need in the future to have some pre-grafted, pre-prepared tissue, not now. Other authors, they tried to show and to use some allograft or some autograft, but all them, they reinforce just the anterior part. But these lax patients, these unstable patients, multidirectional unstable patients, they have the loose tissue in not just anterior, but inferior and posterior. And so we need a procedure that can address the instability all around the joint. Posterior voluntary subluxation. This patient can have late damage of the posterior labrum. From voluntary and not painful subluxator can become a non-voluntary and lose the shoulder, and this can be a problem. This is a CT scan in a subluxator that's overstretched the capsule and gets damned to the running onto the posterior labrum. This is a girl, so she had previous surgeries for the posterior dislocated shoulder, not from me, the previous surgeries, so bone grafting, plication, and fusion. This is another, not the same. This is to say this is X-rays from another patient and not for that, but just for to say that the fusion is mostly performed in patient with a problem of uncontrolled movement of their shoulder. And the problem is that they have bilateral problem. She went to me to ask for the second fusion. And so this is to say that the problem is already non-solved problem, the problem of multi-directional instability. Many patients, they can go over, but there's a small cohort of patients, a small amount of patients, they did not already solve their problem. Thank you. Okay.
Thank you, Enrico. That was I think, most wonderful talk I have ever heard on heart traumatic instability. Any question to Dr. Enrico?
Yeah, Dr. Enrico.
Yeah.
Hello. Yeah. When you are putting that membrane graft, so you are anchoring that graft to the glenoid, or you do additional capsular plication along with the membrane graft?
Three anchors, so 3 sutures, and these 3 sutures, I stop sharing screen, sorry. Share screen, no, how to, okay. After I will try, because there's a presentation that, okay. I have 3 sutures, one at south, one west, one anterior, one posterior, one inferior. So these 3 double loaded suture anchors, they have 1 suture that is for the native capsule and labrum. And when you fix these, you have another more suture that is fixed onto the device. So 1 suture south, 1 suture anterior, 1 suture posterior, and you can use this suture to fix the neolabrum. Then you can give some supplementary stitch if you need, and you often need that.
Regarding the tendon graft, is there any preference only for palmaris longus, or we can take any
no
of
more,
them?
not anymore palmaris longus. So this is a membrane from porcine dermal membrane. So this is you can have this membrane in a package, and you then at the arthroscopy you can stop just a moment, you harvest it, and then you fix it.
Dr.
Okay, what is okay?
Yeah.
Go ahead, Dr. Ranjit.
Yeah. What is your post-op advice for these patients after you do these kind of surgeries? Can you elaborate?
Okay.
Post-op.
So very long. So they are prevented to do anything. So complete a full rest for 6 weeks. They can just train the scapula, but they have ultra sling. Ultra sling to maintain their arm blocked. So at a complete rest, then they retrain. They can just do movement by the elbow, by the wrist, hand, and no by the shoulder. The brace is at 15 to 30 degrees in external rotation, and they are trained before going to surgery. Otherwise, they could not be trained just after surgery. Okay. And then No sports for 6 months, 6 to a year. No sports that can put at risk. So 6 months, almost all.
Okay.
But
Thank
they
you.
are trained to do sports. So they cannot go free to do sports. They just should be directed by a physiotherapist or athletic trainer.
Dr. Enrico, I've got a question about your technique of open Bankart. When you do open Bankart, where do you do the capsulotomy? Do you do it laterally or medially? And how do you manage the capsule and how do you repair the lab?
Yeah, you know that if you do this laterally, so as near procedure, you have the most effective shift, because what you do laterally is much effective than you do medially. But if you have a Bankart lesion, you can have the choice of going medially, whereas the Bankart you open along the same direction of the labrum, and then you fix the labrum, and the same sutures that can fix the two folds of capsule.
Okay.
Dr. Enrico, you spoke about this creating a labrum, but in multi-directional instability, it is not only labral pathology. It is the capsule as well as the stretching of the capsule which is holding the glenohumeral joint. So do you do any kind of check-in procedures or procedures which will create an block to the external rotation? Hello? Block to the external rotation position?
No, I don't, but I know that there are many problems, many pathologies, so not just one. There's not just a labrum, there's not just the capsule, there's not just the muscle imbalance. They all, and we do not have a procedure that can address or can fix all these things. We try to. If there's a loose patulous capsule, we can go for a capsular plication, anterior inferior capsular shift. If the problem is not that, is probably labrum and some other insufficiency, try to do the capsular plication and then augment the labrum. But there is no one procedure that gives a guarantee of success.
Vivek, you wanted to ask?
Yeah. Dr. Garvasi, two questions. One is, when do you actually recommend the surgery in these atraumatic dislocators? You know, with because we know, as you just made the last statement, that there is no guaranteed procedure. Okay, any procedure can fail. Perhaps the only procedure which will stop the dislocation is the fusion. So first question is, when do you actually recommend the surgery? Number one, because every patient who is dislocating will come to you and he says, I want it, you know. One. Second is, what makes you think that and I'm talking about very experienced surgeon, not the beginner, not the mid-level, the surgeons with 10-year long, 15-year long experience in arthroscopy, what still makes you think that arthroscopic, the pan capsular application plus maybe if there's any labral tear would not be as efficient as the open, these capsular shifts?
I cannot say you that one is superior to another. This is a path I'm exploring. So I cannot advise or support this against the capsular shift. So I would say capsular shift has mostly good results, and not so bad results, but has some failures, and relevant amount of failures. I can say more than 20%. So you know that there are 2 out of 10 people probably that have a recurrent problem. So for those that would not have recurrences, probably the capsular shift as this procedure I'm giving, they could be enough, but we cannot say to the patient, I for sure shake my hand, I for sure give you 100% or about 100% of good results. If I would have to train a surgeon to a procedure, the procedure I would train him would be not the labrum augment, but would be the capsular shift.
Any other question before we move on to the next talk?
Yes, there is a question on YouTube channel. Dr. Enrico, it is about your first presentation. The Sunil wants to ask that what type of Hilsek lesion you go for remplissage, the medial one towards the articular cartilage or the lateral one? What is the decision maker in Hilsek lesion?
Enrico?
Sorry, it's for me.
Yeah, it's for you. You first talk.
Okay. So I know that I should not stay at the articular margin, but I can say I try to stay in the middle. The upper part, the lateral part, is not for me so sure, because you could have some remaining part of the through. So I stay in the middle with the 2 anchors that I fix in the middle of the defect, of the hillside defect.
Is that answer, or anybody has any question on it?
No, I think let us invite Karthik for his presentation on technique on Latarjet now.
Okay. So I'll like to invite Dr. Karthik. Karthik, can you share your screen, Karthik? Karthik, can you hear us? Okay, yeah. So I'll just mute everyone, Karthik. You can start, Karthik.
Yeah. Thank you very much for this wonderful opportunity. Thanks, Dr. Enrico, for the enlightening lectures. So I'm going to quickly rush through my can you see me? Can you hear me?
Yes, Karthik, we can hear you and we can see your presentation. Yeah, you can go ahead. We can see and hear you.
Objectives of instability surgery is both mobility and stability, and none other procedure like this, like the Bristol Latarjet procedure, which was historically described by Latarjet, restores both mobility and stability. We all know the mechanism of action, 3 different actions. One is the bone block, the other is the sling effect, and the capsular repair effect. So what basically happens when you do the Latarjet is, so the first picture shows you that when the patient goes into abduction exnotation, there is nothing on the inferior aspect other than the axillary pouch to actually prevent the anterior inferior dislocation. But when you do the Latarjet, what happens basically is the conjoint tendon pushes the subscap down. So the inferior shift of subscap is what is the matter here. So the inferior shift of subscap actually keeps the subscap and the whole sling on the anteroinferior aspect and acts like a hammock. So this is what we are aiming at when we do this operation. And this is the paper which was recently published, and you can see that the indication for Latarjet from the guru's mouth itself is they recommend the Latarjet procedure in any patient. If you go on reading this, in any patient who has got a high risk for failure of soft tissue Bankart. So you can talk about a bone loss, you can talk about heel sac, you can talk about contact athlete, you can talk about failed Bankart. But then at the end of the day, if you think that this patient is a high risk for a failure of soft tissue Bankart, then you can offer him Latarjet straight away, irrespective of any other indication. So, so I got a small thing on. Can you all see this? There is a small. The co-host has asked to start your video. Can you just stop that? It's just
co-host has
asked to start your video. It is just showing on my screen
just
here.
cancel it.
I can't move my cursor on. Just hang on. Okay. Yeah.
Play.
Yeah. Okay. So this is the algorithm which we use. So this is the way we decide on patients who get a Latarjet. So for us, we've discussed already, any patient who's got a glenoid index less than 0.8, and any patient who is a professional athlete or a manual laborer will get a Latarjet irrespective of his bone loss. So the 20% we know all this. Again, the difference between Bristow and Latarjet. So surgical techniques, a very straightforward technique. So I'm talking about open Latarjet here. So this is a classic axillary crease incision. The incision can, as shown the other day, it can be made a very mini sort of incision just exactly in the inferior aspect of the axillary crease, which will be cosmetically very appealing. So a centimeter of the CA ligament is harvested along with the coracoid. So I make it a point to harvest at least 20 mm of coracoid, and the pec minor, I usually just do a tenotomy of the pec minor. I just use a straight osteotome to do my osteotomy. There is no fancy saw needed for this. You just put your homen properly at the base of the coracoid, and then once your homen is there and once it's being retracted properly, you can just use a straight osteotome, and then or a 1-inch curved osteotome, and then you can do your osteotomy without any difficulty with an osteotome. You don't need any fancy saw for this. So once that is done, the undersurface of the coracoid is prepared. So the preparation for this purpose, I use the saw, just a normal saw, and the burr. So once the undersurface is there, so I do a classic European Latarjet. I'll tell you the reasons for it. So once the undersurface is prepared, then I make drill holes. I'll tell you the way I do it. And once the coracoid is prepared, you just tuck it inside the medial aspect of the wound and then do your subscap split. I just do it in the middle of the subscap, not as described in the textbook between 2/3 and 1/3. I just do it exactly in the middle. So once that is done, the next step is the vertical capsulotomy. So the capsulotomy can be done as medially as possible. Once the capsulotomy is done, you can put your humeral head retractor, the faccuda, and once the faccuda is in, you can actually see the glenoid very well. So you freshen the neck of the glenoid properly, and then make your drill holes for your graft to sit in. So it's very important to make the graft and the glenoid in complete contact for good healing of the graft, and that is very essential. And once that is done, once the screwing is done, you just repair the capsule. This is the capsular remnant to the CA ligament stump. And once that is done, you just you need maybe 1 or 2 bites here along the tendinous portion of the subscap. You usually don't need to split the tendon. You just split the muscle. So you don't need to, you will not have the necessity to do any suturing of the subscap split. But if you actually split the tendon a little bit, suppose in a muscular or a bulky patient, you can put a couple of stitches there. So the stabilizing mechanism has been studied, and we all know that the sling effect is the most important, and the bony effect is essentially only in the mid-range. And the traditional, the modified Latarjet, the congruent arc Latarjet actually gives you a little bit more area, but then it is a flimsy sort of a procedure because the area of contact with the glenoid is very little. There is more chance of error in putting the screws in and all that. So we just studied our population for whether we can do a congruent arc Latarjet in the Indian group, and we found that the Indian coracoid dimensions are too small to be able to successfully perform congruent arc Latarjet. So this is my experience. For now, this was last year's data. So we actually do a pre-op CT scan and a post-op CT scan in all of our patients. Nowadays, we do an immediate post-op CT and then a follow-up CT at 6 months to 1 year. So these are some of the follow-up cases. You can see, I'll tell you the exact method of how I do the screw placement. Even in the master's hands, the accuracy of screw placement is about 80%. This is Jill Walsh's data. So these are some of our patients. You can see here, it's very common to actually rotate the graft. The graft can, when you place, especially when the glenoid bone loss is not too much, the superior part of the graft can easily rotate a little bit medially. Though it doesn't matter much, but you have to be very careful in placing the graft because the graft placement decides the success of the surgery. So this is the X-ray done. So this is one of the cases of failed Bankart where you can do a Latarjet very nicely. So the algorithm which we follow actually won the medal in IOA. So this is our study, as I showed you. Now, as I told you, the most important point, the most important aspect of coracoid graft surgery is the placement of the graft, because if it is flush with the glenoid, you're always successful. If you're too lateral, you're going to cause osteoarthritis. If you're going to too medial, you're going to have failure. And all complications of Latarjet, most of the avoidable complications are technique related. So it's very important to have a proper technique. So all these complications of bone block non-union, fracture, resorption, arthritis, and implant-related complications can be prevented by a proper technique. So the big scare about doing a Latarjet procedure is because of this, because when you don't place the screws properly, when you don't look for the position of the graft, then you end up with a lot of problems. So this is the Bernagio view described for how to take the X-rays. So it's very important to place the screw below the equator, and then you have to maintain the I'm just unable to move my cursor here. So if you can see, it doesn't matter if you have to follow the straight line here. Even if your graft is slightly jutting out there, when you draw this humeral circle, the slight lateral placement of the graft there does not actually come into contact with the humeral head there. So the arc of motion is maintained. So circumferential measurement assessment is also important. So what I suggest is, so these are some of the complications in the hands of masters. You can see if a badly done Latarjet actually can result in a lot of problems. These sort of bent screws, especially the patient is, look at the sort of heel sac and the anterior bone defect he has. This is the graft which are just pulled out of the coracoid. So these are the complications which can happen in imperfect surgery. So it can be prevented by good surgical technique. So how to perfect the screw placement of Latarjet? It's a simple freehand technique which we actually published, and we actually won the medal for this. So what we do is we actually measure all our patients, measure the coracoid dimensions in all the patients we do. So measure the length, breadth, and width. And we also, so once I drilled a hole in the inferior aspect of the coracoid, pre-drilling, then I measure the distance between the lateral aspect of the coracoid and the hole. So which is usually about 7 mm according to Jill's Walsh, but most of the time we found up 6 mm and sometimes even 5.5. If you use a proper caliper, you can actually exactly calculate the distance between the hole and the lateral aspect of the graft. So once you've calculated that, I just use a paper scale to cut it and then place it on the glenoid neck. And once you do that, you know exactly where to drill the hole. And once you do that, every time you can get a proper flush graft. So we started doing this because we started this because all the commercially available jigs were either too big for our glenoids. And the problem with the commercial jig is both the screws have to go in the same direction. Now, the problem if both screws go in the same direction is that many times you can see in this case, you can see that the medial aspect of the glenoid is, the graft is not flush. So if one screw can be directed a little more obliquely, so the graft contact will be better. So that has been proven in studies, but that possibility is not there if you use a jig like companies provide. So these are some of the post-op X-rays in our patients. We found that the accuracy was 93% in our cases. So we measure accuracy of screw placement in all our patients. And that's how we started learning. And then we did a follow-up study of from 1 to 2 years. We did the follow-up CT scans for all our patients, and we measured resorption also. So this is what I was mentioning. If the glenoid, the graft is slightly lateral, and then if it doesn't come in the arc of motion, still okay. And that's very important. Again, all these things you will learn from your own patients if you do proper post-op imaging. So the alpha angle, again, the angle of screw placement, how much screw is jutting out posteriorly, whether it is angulated superiorly. One of my patients actually had a temporary infraspinatus palsy because the screw was too long and posteriorly touching on the suprascapular nerve. Luckily, he recovered without any problems. So these are things which you measure in your post-op X-rays. So the drill guide, the problem with the drill guide is that both the screws go in the same direction. This has been recognized. This problem has been recognized. So whenever you use a drill guide, the coracoid graft contact actually is not as good as doing it freehand. So you have to understand it. So that's the advantage of when you use the drill guide, both the screw holes are in the same direction. But when you use freehand technique, actually you can just have a little bit of a divergent screw so that your contact is better. And with our technique, where you use a measure with a caliper and use a small paper scale, you don't need all these expensive jigs. You can just use simple technique to have the best sort of contact with the. So the advantages of this technique is helps accurately place the inferior hole with the measurement of the clavicle, and the superior hole you can actually adjust. So you loosen the inferior screw a little bit, adjust the graft nicely, and then you can aim your superior hole and get the maximum contact. And we've shown very good results with this study. So some of the conclusions: Indian coracoid dimensions are significantly small for a congruent arc, so keep that in mind. A freehand technique actually allows placement of screws in different directions to achieve good compression, and accurate screw placement is obviously essential, and it can be very easily done with a caliper. And we also studied coracoid graft osteolysis, and 20 patients followed up for 2 years. And we also measured the subscap strength in these patients actually. So we found that coracoid osteolysis is a fact. It happens, but it happens mostly in the superior aspect. So osteolysis was definitely noticed 80% of our patients, and it was mostly on the superior aspect in 7 of the 16. And distal aspect of the graft was the least involved, as we all know, and it had the best union. And that's what matters at the end of the day. You don't need the proximal aspect of the graft at all. And what we interestingly noted was, even when we did the subscap split, the subscap muscle strength was found to be weak in 60% of the subjects. And the mean, there was a significant difference between the two sides. So this was something very interesting, whenever when you do a subscap split, actually you're damaging the muscle. So you need to keep that in mind. So subscap split is not without its problems. So you need to be very gentle to the muscle. So that's something which we found was interesting in our study. So obviously there are contraindications for Latarjet. These are the contraindications: large cuff tear in older population, voluntary dislocation, uncontrolled epilepsy, micro instability. This is something you need to keep in mind. In my hands, I do Latarjet with Remplissage in a very select population of locked anterior dislocation with large humeral head defect. We have seen some patients and some surgeons using allograft for the humeral head defect, like just now Dr. Enrico showed us. But allograft availability is not that much in our area. So what I do in such patients is I actually do a Latarjet along with an open Remplissage. So this is an old man who has actually had a neglected anterior dislocation, and it's the result at 6 months. This is another patient with a neglected 6-month-old anterior dislocation, where Latarjet, see, when you do coracoid osteotomy, you get a good exposure. You actually reduce the shoulder, and then you can do a mini posterior incision, cut through the cuff, and then medialize the cuff incision by doing a open Remplissage. This is just off the books. This is not been reported anywhere. But this actually, we can achieve very good outcome. This is a manual laborer has gone back to his bricklaying work after surgery. So take home, I think this Latarjet operation is a very cost-effective solution to shoulder instability. It's the non-anatomical reason and the long-term concerns have been mostly alleviated now, because we got 20-year results coming from Jill Walsh and others. It's a good, but what you have to keep in mind is a good surgical technique is needed to avoid complications. And get post-op imaging and learn from your own cases. It will be very useful. And arthroscopic Latarjet is still very costly and dangerous, I think. Thank you very much.
Thank you, Dr. Karthik, for wonderful talk on Latarjet. Now, is there any question to Dr. Karthik on his talk?
Dr.
Yeah,
Karthik?
Vivek.
Yeah, Karthik.
Yes, sir.
A fantastic talk here. Quite nice. Very elaborate. One of my question to you is, in your talk you said that almost all professional athletes. Now, what is the definition of this professional athlete? Are you talking about any athlete, or is it only the athletes who are contact sport, or let's say badminton player, with recurrent dislocation versus a football player with a recurrent dislocation? So what is this definition of professional athlete?
So professional athlete by definition is having sport as his career. Okay, so these are patients who come to us. When I see these boys and girls, I talk to them. I give them.
Can I interrupt?
Yeah.
Maybe tennis player.
Yeah. No, I'm just coming there. What is the difference between overhead and contact? I'm just coming there. What we thought was in an overhead athlete, especially in a patient who's playing tennis or badminton, you need the proprioception for the placement of the hand here, and there is no contact involved. So we thought that the Bankart probably is a better operation in them. And when you talk to the patient, we give the options to the patient. I most of the time I talk to the patient telling that, see, this is the operation. This is a soft tissue operation, arthroscopy, keyhole surgery. This is the recovery time, and this is the result. And then there is another operation, which is the Latarjet operation. This is also being widely done everywhere. And this is the result, this is the outcome, and this is the return to play time and all that. Invariably, all the athletes, irrespective of their sport, they have chosen Latarjet. So, and that's what I found. And still today, I discuss the options with them. I give them the options. And this is what they seem to want. Dr. Enrico, what do you think?
Unmute, Dr. Enrico. Unmute.
You have to unmute yourself. Yeah.
I did. So you can tell, as you do, the sportsman the choice. You can give him the information, the full informations. So here in Italy, we have many patients that they want to do a Latarjet procedure because we are very close to France, and they are pushed by the opinion that the Latarjet gives a very low recurrent rate, and compared to the other procedures. But we know that even in good hands, I cannot say Gilles Valch hands, but because this is his procedure, and he has a very, very nice outcome. But in the hands of the overage, we have some complication or some unwanted problem, and should be said that to the patient as well. So for me, when I'm facing very young contact sportsman that asks me for the most secure surgery that prevents recurrences, I have to say him yes, Latarjet. But if I would manage a shoulder that has no huge bone insufficiency and not tens of dislocations, I would prefer for another surgery. However,
Vinay, you wanted to ask something?
Yes.
Karthik?
Yeah.
So, do you ever do application for you in a first-time dislocator doing a Latarjet?
Sorry, I couldn't hear you well.
So, there's a first-time dislocator.
Yeah.
Do you ever perform any indication for doing a Latarjet in a first time dislocator?
No, not in my hands. No, I don't do Latarjet in a first time dislocator.
Karthik, there's one question for you, and I'll ask another question to Roshan. So, Karthik, there's a question on the group. Somebody has asked that you said that after the Latarjet, there's a 60% loss of strength in subscap.
Yeah.
I mean, there's a considerable, I may be wrong in percentage, but
No,
there was a considerable loss of strength.
Yeah.
Okay. And so the somebody has asked that do you do the MRI? Because there are some reports that after doing the Latarjet, there's a subscap fatty infiltration. So do you ever correlate doing the MRIs in those patients, those who are losing their strength, that is there any, fatty infiltration?
So the average difference between both sides was 1.8 kg. It's not, and it was seen in 60% of patients. So it doesn't, not in, So the difference is about 1 kilo on both sides. And this is something which we actually just wanted to see, with the subscap split, was there any problem in the subscap muscle itself? And I mean, this is very interesting to note that there can be fatty infiltration after the, so we haven't done MRI in those patients. So maybe this is something which we can look at. Thank you.
Karthik, in your follow-up CT scan, you said that there has been resorption in the superior portion of the, right?
Yes.
So is it not testimony that Bristow used to work with sling and small bone fragment, and we are putting too large piece of bone in Latarjet all the time?
The thing is, sir, I absolutely agree with you. In the setting of no bone loss, Bristow will work very well. The problem with Bristow operation is that the initial primary fixation is a little flimsy. You got a small bone and you got a single screw. In most of the American studies, the Bristow surgery was the one which had a lot of complications because of this. Either they were unable to place the graft, achieve good union. Sometimes they cracked the graft. So the whole surgery went into disrepute because of that. What the Latarjet gives you is a nice bony chunk to work with. So the primary stability is so good. And after the fixation, you are so confident that you can mobilize the patient soon. If you do a Bristow, I'm sure we will still have that, we will not know whether to mobilize him, wait for the bony union and all that. Here you got two nice screws really pushing the graft towards so that's the advantage, I think.
Karthik, excellent presentation actually.
Thank you.
I just wanted to bring to your notice that when we pre-drill the coracoid, sometimes I have observed that depending upon the architecture of bone loss of the glenoid, you are fixed in your angle, alpha angle.
That's true, sir.
Right? But when you want to improve your angle in that direction, you don't have the choice.
Yes, sir.
So is it not a good idea to just fix a coracoid with a K-wire and then drill the drill?
Yeah. So earlier I used to drill both the holes, but now I drill the inferior hole only. So when I drill the inferior hole, I still have got a little bit of a leeway. I measure everything exactly, and then I drill for the superior hole. Then I can actually rotate the graft any which way I want, and then use my guide wire to pin it, and then do a cannulated drill.
Yeah.
So I agree. I can use a K wire and then manipulate it better. But then this actually gives me a lot of. Once I'm there, I have already got a hole. Then I can actually place it and then fix it easily because I go with the screw itself there. I actually drill the glenoid and the thing separately, and I go with the screw with the graft and then go in and then fix it.
Vivek, your question to Roshan.
Roshan.
Yes.
So what is your take on this Latarjet in professional athlete? What are you doing?
See, I will tell you. Yeah. I will tell you the story of my Latarjet experience. I'm not a very big fan. Yes.
Let me say, because I have not operated, of course, on so many professional athletes. Even if I have operated, I have been a bit choosy. Unless and until the bone loss is more than 15%, and as Karthik very rightly said, we also discuss with them, if they really say, okay, you do Latarjet, then I do. But I would sometimes maybe err a bit more on the Bankart plus remplissage, maybe because I have a bias. I've been doing it for a long time. There have been a lot of successful results. So I may have a bias in my mind. That's why I want to know everyone else's opinion.
Sir, I just
I'll let
add
Roshan.
in my group.
Karthik.
I know. I'll just tell.
Okay.
I want to tell that in my group, the majority were manual laborers. I had 10 elite athletes,
Okay.
kabaddi players, boxers,
Mm-hmm.
and bowler. So
Okay.
there was only a couple of bowlers. There were boxers and kabaddi players mainly. So I actually, in my study, I have there are no badminton or tennis players who are elite athletes. So who have actually had instability and come with us for surgery. So that I just want to register.
Was there also an element of finance in your study? I mean,
the manual laborers, yes. So the majority chunk who get primary Latarjet are the manual laborers, and the whole surgery is so inexpensive, and they are very, very happy because they're able to return back to the manual.
True.
I'll tell you my experience because I've been involved in a lot of shoulder surgeries at KM Hospital since last 15 years. I'm not a very great fan of Latarjet. Let me make it very clear. I have not done more than 20 Latarjets, maybe 19 to be precise, in my whole career. I'm not a very, fact is fact. I can't change the fact. And I have done this Latarjet mostly in my mixed martial art patient and kabaddi players. So I have a certain different class of patients which attend me because I'm attached to mixed martial art association. I see a lot of contact sports in that, and few wrestlers and few kabaddi players. But I'm not a very, very great fan of Latarjet because I'm not yet convinced that this surgery is going to give you a pain-free, mobile and stable shoulder for quite long duration. I'm not talking about the short-term duration of. Second aspect of the life is very important, that whenever our athlete who dislocate once, twice, thrice, they try to change and adapt their position in the game. They try to change it, and even if I tell them that they have to undergo Latarjet, they will not. They will try to choose something which is better, cosmetic, and the threat of open surgery versus the arthroscopic surgery. So they try to accept the option of more arthroscopic, minimally invasive procedure. But frankly, I'm not a very, very great fan of Latarjet. Somehow I don't get those kind of patients where I can offer them huge number of surgeries. Mind you, we do enough number of Bankarts to say this.
Karthik, there's another question for you from Vishnudeep. He says, because of loss of strength in sports where there's a lot of internal rotation, strength is required, do you think it will be relevant?
No, we are talking about a very small loss of strength. This is just a incidental sort of finding. This, yeah, maybe if the patient is holding a ball here in rugby and then running, maybe that is, or maybe in say in sort of boxing when it's sort of coming there. But see, we forgot national level boxers whom I've done Latarjet on both sides. The primary Latarjet, it came for one side, and then after 4 years, it's come for the other side. Very, very happy they've already won medals. So I think the loss of strength is, as its impact on sport will be very, very little. So this is something. This loss of subscap strength of Latarjet has not been studied much. So this is one of our studies actually.
Okay, there is one more question on YouTube. Dr. Tirth Vyas has asked, what do you do when you have a small coracoid process which is not good enough to be fixed? Like what we see commonly in our short stature, thin patients where coracoid length is not sufficient enough to create a Latarjet type of surgery. Karthik?
We measured the coracoid in 80 cadavers, and then after that we measured the coracoid graft size in all my patient surgeries I do, and we found that the average length in Indian patients is about 22 millimeter. Regardless of the stats. So the only thing is, if you get say 16 or 17, you go for a 2.7 mm screw. So always keep a 2.7 mm screw box ready. So if the graft size is short, then you can use smaller screws.
Yeah,
yes,
Roshan.
Yes, Samir, yes.
Regarding to this coracoid length, what just now Karthik said, even we have done a cadaveric study at Alamein. So even we have found that it's around about in between 23 to 24 mm. Then while doing arthroscopic Latarjet for me, I am doing with the Depumitex double barrel cannula. So now we have done almost 70 cases, but we have realized that for Indian patients, we need the different zig for that. So arthroscopic Latarjet panel we have discussed in Bangkok last year, and we decided to come up with a smaller type of zig, alpha beta zig, that will accommodate the distance between the two screws. Initially it was 8 mm, now we are coming up with 6 mm.
6 is better. Yes.
Yeah, we are coming up with 6 mm so that for while doing a drill holes for arthroscopic Latarjet, the life becomes easier in Indian patients. Yeah. And others, all French people, they are using the routine zig what we are having at present.
Yeah. Okay, if there is no question, I think we should move on to the last and most awaited talk by Dr. Enrico, that is management of failed arthroscopic Latarjet. How do you manage this? Because doing Latarjet itself is very complicated, and managing that complicated surgery with more complex situation, only if you masters can do it. So one of them is Enrico. Enrico, please enlighten us with your talk.
Okay, so I share the screen. Okay, so share the screen.
Okay, I'll mute everyone.
Okay.
Just a minute, I'll mute everyone so that. Okay, here we are. You can go ahead.
Can I go?
Yes, yes, I can see you. We can hear you. You can go ahead.
Okay, okay. So, Latarjet, as I told you before, is a wonderful procedure, but when we do it, we have to be conscious that some patient has some problem or can have some problem. There's this patient that has a gliding humerus onto the graft. Revision cases, and I can show you some case just in order to the take-home message that is if you do this procedure, you should be very, very trained, and the risk for a failure there is, however, and the Latarjet failures are very demanding to be treated. So this is open Latarjet. This is the plate of Giovanni Di Giacomo, that is a wonderful surgeon. This plate is made by him, not the procedure, but the procedure looks properly made. So a proper position of the graft, and however, the patient bended the screw and had a recurrence. So this is what I saw inside. See, so there's the graft and there's the screw that is protruding, and there's some soft tissue, the remaining soft tissue that is here, and that there's a decubitus of the metal onto the soft tissue. Most of the surgeons, but fortunately not this one, they take off all the medial labrum capsule and whatever. If you do that, you can have nothing for the way out from that disaster. So I use a half pipe coming from anterior, and this half pipe is from the hip arthroscopy. So you can reach without a cannula, you can reach the C2 where there's the metal, where there's the there are the device, the screws, and so on that you have to withdraw. You have to take all these off. All these off, you have the risk for some cartilage damage, and you now have to fix the heel sacs lesion. You know that when you do a open Latarjet, you mostly do not do anything to the posterior labrum, to the posterior humerus, nothing. And so I suppose that in the future, the Latarjet would be done arthroscopically, because in this way you can manage to treat the combined lesions that the operation by the front cannot do. So in this way, you can fix the posterior part of the capsule. You can fix the anterior part, and then you can go out of this problem, go home. This is open Latarjet, and look at how the screws are medial, and so when you do a X-rays or CT scan, whatever, just after the procedure, you should not leave the patient this way, and you have to take this off and to relocate properly. And this is the same patient the next week after the index surgery that was treated. So it is possible. This is a patient treated by me, and this is possible that you do some mistake. Anyone can do some mistake. So late open Latarjet failure, open revision, iliac crest graft. And this is for a patient that had this breakage, and after the Latarjet, you may have a thick, dense, fibrous tissue, and the tissue is just scared with the axillary nerve. What can you do in this case? You can leave all the things that are about the graft, the coracoid graft, to not having damaged the axillary nerve, and fix the iliac crest graft. Early arthro-Latarjet failure. First, early revision, open, and second, early revision, arthroscopic. This is the worst case I did. I am showing this, that is a failure, my fault. So this patient went to me in this way. He had bony resorption over the years, but he was able to climb mountains, as he was a mountain climber master. So suddenly, in an accident, he lost the ability to control the arm, and he came to me after weeks with the arm at the side, with no chance of opening for a few degrees the arm from the chest. So he lost the neuroception, he lost the ability to control the arm. So I went to the surgery, and this was my, I did this arthroscopic Latarjet. I accepted some medial position, but look at as the patient had the anteriorly subluxating humerus, and this was riding over the graft, over the coracoid graft. So I told the patient, I'm sorry, I have to revise your shoulder, and I did that open in a couple of days. But this was not better, and I had to revise the surgery. So again, I treated the heel sacs lesion. 3 anchors to the heel sacs lesion, but the humeral head was still subluxating anteriorly, so I could not be able to go home with this situation. And so I tried to fix the subscapularis, the interior subscapularis, at this level and at this level with the screws, as I would do a cuff repair. And in this way, this very narrow glenoid with the screws here to fix the subscapularis to improve the stability. Now I recentered in this way, I recentered the humeral head. This is the X-rays, post-operative X-rays. 3 screws for the remplissage onto the humerus, 2 screws, 1 distal, 1 proximal for the stability of subscapularis, and 2 screws for the coracoid process. So, and how to say care that in years it is possible that you are in trouble, in the mess after treatment, after failure, a Latarjet failure. This is a young patient, a wheelchair with recurrent instability. I did not that Latarjet, but was given by another surgeon. Just to say that not all the problems comes from me. So the coracoacromial arch was killed. He had developed neurological problems, so the plexus problems with some with problems at distal of the arm and unrepairable cuff tear. So anteriorly subluxating the arm, and this was the huge, after the Latarjet, this is the huge ossification, and we have no anymore any remaining coracoacromial arch to prevent some anterior superior dislocation. This is so no subscapularis that was jeopardized by the previous Latarjet. So I went for the resurfacing implant. I took I did the release of the plexus. I took all the bone that we saw before from the plexus nerves, and I transferred the pec major. So he solved the problem by the neurological problem, but not at all the arm function. So what would we say as a take-home message? Take-home message is look that the subscapularis itself is help mind the subscapularis, and that could be your friend in the Latarjet or any instability failure after Latarjet, either arthroscopic or open. Okay.
Okay. Do we have any question for Dr. Enrico?
Dr. Enrico?
Yes,
Yeah.
Vinay, yes.
So, what's the status of rotation after this salvage procedure? Do you find any restriction of rotation in these patients?
Yeah, but you want that. The problem is a patient with a dislocating shoulder. So easily dislocating shoulder is unhappy. He wants whatever, but he wants you fix his dislocation. A procedure, you do a procedure that can fix the shoulder and have no recurrences, no dislocation recurrences. So the second level, now the range of motion comes in a very low level of priorities.
Okay, any other question for Dr. Enrico?
Yeah, Enrico, you mentioned in your first presentation about reverse heel sac where you use the split subscapularis.
In the reverse heel sacs, yeah.
Put subscapularis.
Yeah. Do you say in the open or in the arthroscopic? Because you can do the both. If the McLaughlin lesion is not so huge, you can do this arthroscopically, and you can fix the subscapularis there. The muscle part of the subscapularis is mostly free gliding, and so there's no problem. You maintain 45 days in external rotation sling, and that's it. If you have a huge heel sacs, so 30% of humeral defect, you have to graft it. Graft the bone.
Thank you.
So,
welcome.
Dr. Enrico, when you do the subscap attachment to the reverse heel sac, do you detach the subscap from the humerus and then attach?
No, I just refresh, so scapa and capsule because they are connected.
Yeah.
Yeah, and when you refresh that, you fix that, and that's it. But your main problem is not that the defect would, if you do that arthroscopically, would go behind, but this is mostly because it pulls the head against a posterior dislocation.
And when you do the subscap tenodesis for the anterior failed, so when you do that, how do you do that? You just take a bite on the subscap and then fix it to the glenoid?
It depends, because there is the technique I showed you is subscapularis onto the scapula neck, just under the distal part onto the scapula neck, just under the rim, the glenoid rim. So you have the subscapularis that is not detached, not away, not loose and that is what gets stable a capsule that would not be sufficient to prevent dislocation. So when you do the tenodesis of the subscap, meaning the upper part of the subscap, the tubularis part of the subscapularis, this is a procedure that is supported, ideated by an Italian guy. His name is Marco Maiotti, and he does that as a support of a Bankart repair, especially for patients that have some elasticity of the subscap, or some not too rigid patients. So it is for patients that have some laxity. And so he supports that with the tenodesis of upper part of the subscapularis. This is a nice idea. It comes from other authors as Lenny Johnson in the mid-80s and so on. And in patients with some elasticity, some lax patient, even Jill Walsh says you have not just to do the split at the 2/3 proximal and 1/3 distal, but at the mid subscap, in order to involve a greater part of the subscapularis to the stabilization.
To Enrico, in how much percentage of patients of primary Latarjet you do remplissage?
With the primary Latarjet, do you mean Latarjet at the first episode, or primary Latarjet just?
Primary Latarjet anywhere you are doing. How many times you do a remplissage along with that?
Now I am doing. I cannot say the percentage, but I say you that now I'm trying to improving my repair, and I go by the scope first. If there's a huge hilights, I put the screws, I pass the sutures, then I don't fix the sutures. I do the Latarjet, and after the Latarjet, I go to close, to tie the knots of the remplissage. So the steps are: patient with well-known Hill-Sachs lesion, you plan to do Latarjet plus remplissage. You go by arthroscopy. You pass the sutures through infraspinatus and posterior capsule. You leave the sutures with not tying the knots. Otherwise, you would be prevented to dislocate the humerus posterior by the Fukuda retractor. Then you do the Latarjet, and when you go home, you tie the knots at the posterior side.
Is there any question to Dr. Enrico, or we can leave? We can conclude the meeting. Sanjay Trivedi.
Yeah, one more question. I can ask one more question.
Yes,
yeah,
Samir,
Dr.
yes.
Enrico, like as we all are doing Latarjets, and we see there is some sort of divergence of screws, what we see when we are doing arthroscopic Latarjet. So how much clinical difference does it make, this divergence of screws?
Soft screws? No.
Yeah.
I'm sorry, but I didn't understand the question.
In Latarjet, we are placing the screws parallel to the glenoid. We are trying to put the screws. But on post-op X-rays, we see there is some divergence. How does it make clinical difference?
Divergence or protruding?
Divergence.
Divergence, okay. It is nothing to do. If protruding, you cannot leave them.
Okay. So I think that's all for today. Today was a very wonderful webinar. I thank Dr. Enrico. I thank
Thank you.
Yeah, it was wonderful. We'll invite you again for some other topic, Enrico. That was wonderful to have you. I thank Dr. Sanjay Trivedi, Dr. Vivek Pandey, and Dr. Karthik Selvaraj for enlightening us on different topics. I thank other panelists, Dr. Ranjit, Dr. Vinay Pandey, and as well as Dr. Samir Sheikh, and my friend Dr. Sandeep and Abhishek Nerurkar. Thank you, everyone. Thank you, Enrico. If you want, you can leave. We'll stop the live streaming.